Welcome to the Deep Dive, where we take dense info and make it clear and actionable for you.
Yep, helping you connect those dots.
Today, we're getting into something that seems basic, but honestly, it's really critical and have a lot of layers. Patient hygiene. We're pulling this straight from the Fundamentals of Nursing, the 11th edition, by Potter, Perry, Stockert, and Hall.
Good stuff in there.
Our mission here is to really unpack the core ideas of nursing hygiene, focusing hard on, clinical judgment and how you actually use this stuff in the real world.
And to make it stick, we're following a case study, Mrs. White. She's 78, colon resection, complex history, rheumatoid arthritis, diabetes, hypertension, BMI of 40.
Wow, okay. So she's got a lot going on.
She does. And her challenges will really highlight how personalized hygiene care affects, well, everything. Comfort, safety, well-being.
So let's start right there. What is hygiene in a nursing context? It's obviously more than just a bath, right?
Yeah. Oh, absolutely. Yes, cleaning and grooming are part of it for appearance, but it goes way deeper. It hits comfort, safety, even how well a patient feels overall.
It's like a hidden factor in healing.
You could say that.
Yeah.
It impacts infection control, mental state, even discharge times. If you neglect it, it's not just uncomfortable, it can be clinically risky.
Right. And doing this kind of care means getting physically close to patients.
Exactly. Which means therapeutic communication is non-negotiable. You're not just listening. You have to build trust, be really sensitive. It's a vulnerable position for the patient.
And you mentioned it ties into assessment.
Totally. While you're helping with a bath, you're also assessing skin, maybe checking range of motion, looking at IV sites, changing dressings. It's multitasking patient care at its best.
Okay, so it's integrated, but it can't be cookie cutter, can it? Everyone's different.
Definitely not. Hygiene is super personal. Think about your own routines.
True.
So a ton of factors influence it. For Mrs. White, her lifelong habits, what products she likes, even her cultural background.
Right.
It all matters.
Makes sense. So what are some of those big factors we need to consider?
Well, personal preferences are huge.
Okay.
And you've got social factors like family customs growing up, maybe how often you bathed as a kid. Body image plays a role, too. If someone's perception of their body changes because of illness or surgery, their desire for hygiene might, diminish.
I can see that. What about things like cost?
Big one. Socioeconomic status impacts access to supplies, or even if they can afford things like grab bars at home for safety. You got to think beyond the hospital.
And it's not just knowing what to do, is it? It's about motivation.
Right. Health beliefs are key. If Mrs. White, with her diabetes, doesn't really believe she's at risk for foot problems, just telling her to check her feet, well, it might not sink in.
She needs to see the why.
Exactly, the personal benefit. And culture is huge here, too. Box 40.1 in the text highlights this. Privacy needs, modesty, preferences for caregiver gender, even timing around prayers.
So as a nurse, you have to be really aware and non-judgmental.
Absolutely. Offer choices, explain things tactfully, make sure care aligns with their culture.
And age is obviously a factor, too. How does that change things?
Dramatically. A newborn skin is super thin, bruises easily. Compare that to an older adult like Mrs. White. Their skin gets thinner, drier, loses elasticity, higher risk for injury.
And foot problems become more common on older adults, too, right?
Oh, yeah. Corns, calluses, infections, often from years of wear, maybe poor-fitting shoes. Plus, they might just lack the strength or dexterity for good foot care.
Which brings us right back to Mrs. White and her rheumatoid arthritis, that pain and hand deformity directly impact her ability to care for herself.
Precisely, and that underlines why we must understand conditions that impair hygiene. Think about sensory deficits if someone can't feel hot water due to neuropathy.
Huge burn risk. Safety has to be number one.
Always. Then chronic illnesses, cardiac, pulmonary, cancer, mental health issues, they often cause fatigue, shortness of breath, pain. Self-care becomes exhausting.
So you have to pace things, maybe give pain meds beforehand.
Good idea. Give analgesics maybe 30 minutes prior, but watch for sedation. And limited mobility, whether from obesity like Mrs. White, injury, or even just IV lines and catheters, makes things tough.
And cognitive issues, like dementia.
Right, stroke, dementia. Patients might not be able to do self-care, or they might get scared or agitated during care. Requires a lot of patience and a gentle approach.
Okay, so there are a lot of factors. How do we pull this all together for someone like Mrs. White?
That's where the nursing process and clinical judgment really shine. It's not just following steps, it's thinking critically.
Do you break down that clinical judgment piece a bit? The book mentions figures like 40.1, 40.3.
Sure. It's basically synthesizing everything, your knowledge, your experience, the patient's situation, critical thinking, standards of care, It's iterative. You notice things, recognize cues, figure out what they mean, analyze, decide what's most important, prioritize, plan solutions, act, and then check if it worked. Evaluate. It's a cycle.
Got it. So let's start with assessment the eyes of the nurses.
Right. Hygiene is personal, private. Building trust is step one. You need to find out their preferences, their usual practices, their emotional state, what they already know or need to learn.
So asking something like, how can I best help you with your bath?
Perfect example. It opens the door. Box 40.2 talks about assessing through the patient's eyes. And you need to assess their actual self-care ability. Like figure 40.2 suggests, watch them do a task like brushing teeth, see where they struggle.
For Mrs. White, that might show her difficulty gripping the toothbrush because of her arthritis.
Exactly. And note, medical devices, tubes, IVs, they need special care. Also involve family, like Mrs. White's granddaughter. Assess their ability and willingness to help, especially for discharge planning.
And checking the home environment for safety hazards.
Crucial for discharge. Can they safely use their bathroom? Do they need grab bars, a shower chair?
Okay, let's get into the specifics of the physical assessment. Skin first, tables 40.1, 40.2, 40.3 guide this. What are we looking for?
You're inspecting everything. Color, texture, thickness, turgor, that's skin elasticity, temperature, hydration. Look for any lesions, dryness, cracking, redness.
And under medical devices, like oxygen cannulas.
Definitely. High risk for medical device-related pressure injuries, or MDRPI. Check skin folds, too, especially for bariatric patients like Mrs. White under breast in the groin. Keep those areas dry. Maybe use cornstarch.
What about different skin tones?
Great point. Assessment techniques might need adapting for darker skin. Conditions like hyperpigmentation or melanoma can present differently. Be aware.
Okay, feet and nails. Table 40.4. You mentioned this is critical for diabetics.
Absolutely critical. Inspect all surfaces between the toes, soles. Look for any cuts, calluses, ulcers, deformities, and check circulation. Feel for the dorsalis pedis pulse on top of the foot, posterior tibial behind the ankle. Assess sensation. Can they feel light touch, temperature?
Lack of sensation is a huge red flag for injury.
Right. Huge. That's diabetic neuropathy. Also, watch their gait. Are they limping? That could signal foot pain. Nails should be smooth, pink. Changes can indicate health problems.
And the mouth. Table 40.3 again.
Yep, oral cavity tells you a lot. Check lips, teeth, gums, tongue color, moisture, any sores. Look for gum inflammation, gingivitis, cracked lips, cheilitis, cavities, missing teeth, bad breath, halitosis.
Who's at higher risk for oral problems?
Lots of people. Dehydrated patients, those NPO, nothing by mouth. Oxygen users, chemo patients, diabetics, anyone intubated, big risk for VAP, ventilator-associated pneumonia, even patients with cognitive impairment.
Okay. Hair and scalp. Table 40.5.
Hair condition reflects general health. Look for issues like dandruff or, importantly, ticks or lice. Pediculosis lice needs careful management. Wear gloves. Check for head, body, or pubic lice. Provide treatment and educate about cleaning combs, linens, vacuuming.
Right, prevent spreading it. And alopecia, hair loss, is another thing to note.
Yes, and for bed-bound patients, hair can get really tangled, so assess their ability to manage it.
So, back to Mrs. White. What did Jamie, her nurse, find initially?
Assessed her pain at 7 out of 10, which improved to 2 after pain meds. Found redness under buttocks, thighs, breasts, skin was intact but inflamed. Confirmed decreased range of motion, inability to grasp, and Mrs. White was understandably upset about needing help.
Okay, so all that assessment data flows into the next step. Diagnosis.
Right. You analyze the cues, spot patterns, and form nursing diagnoses. Box 40.3 gives examples. For Mrs. White, Jamie identified self-care deficit, impaired ability to bath related to her arthritis.
Makes sense. What else?
Also, risk for impaired skin integrity based on that redness, her limited mobility, and her BMI of 40. That redness is a warning sign for potential pressure injuries.
So the diagnosis connects the problem to the cause.
Exactly, and that's vital because the related to part guides your interventions. For example, treating impaired oral mucous membrane related to malnutrition is different than treating it if it's related to chemo side effects.
Got it. So diagnosis leads to planning and setting outcomes.
Yep. Develop a plan with the patient. What are their goals? What are their preferences? Integrate your knowledge, standards like those from wound care organizations, WCN, or the American Diabetes Association, ADA.
And the outcomes need to be specific.
Patient-centered, measurable, achievable. Like, patient will independently bathe using a shower chair by discharge. Or, patient demonstrates correct technique for foot inspection.
How do you prioritize? Mrs. White has multiple issues.
You look at what's most urgent. Pain control before bathing, for instance. Address the issues causing the greatest risk or discomfort first. Timing matters, too. Try not to interrupt meals or therapy.
And teamwork is key here. Figure 40.4.
Absolutely essential. For Mrs. White, collaborating with occupational therapy, like Jamie did, to get adaptive devices that shower chair, a special wash mitt is crucial for independence.
And involving the granddaughter for discharge teaching.
Yes. Assess her ability to help, teach her what's needed, maybe explore options like a home care aide if necessary.
All right, let's talk implementation, putting the plan into action.
This is where the caring really comes through. Reduce anxiety, ensure privacy, provide comfort like that pre-medication for pain, and teach as you go.
Like Jamie encouraging Mrs. White's input and explaining the adaptive tools.
Exactly, empowering the patient. A big part of implementation is health promotion, teaching techniques, explaining risks, adapting things for home. Safety is huge. Water temp, preventing falls on wet floors, infection control.
Okay, bathing and skincare specifically. Box 40.4, 40.5, skill 40.1 cover this. What about those CHG baths you hear about?
Ah, yes. Chlorhexidine gluconate, or CHG. Many hospitals use it now, often as wipes, to reduce nasty healthcare-associated infections, MRSA, VRE.
So it's better than the old bath basin.
Evidence suggests yes. Those basins can actually grow biofilm, like a slime layer of bacteria. CHG provides ongoing antimicrobial action on the skin.
How do it work with the cloths? Skill 40.1, step 21A2 mentions this.
Typically, it's a pack of cloths, often 6. Each cloth is used for a specific body area, like one for each arm, one for the chest, abdomen, etc. You wipe the skin thoroughly.
And then rinse it off.
No. That's the key point. You let it air dry. Do not rinse. Rinsing removes the residual antimicrobial effect.
Good to know. Does it feel weird?
It can feel a bit sticky. You should definitely explain that to the patient beforehand so they know what to expect.
Are there places you shouldn't use CHG?
Yes. It's generally safe on superficial wounds or rashes, but not for deep burns, 3rd or 4th degree. And critically, avoid the face, eyes, and ears.
What about patients with dementia during bathing? Box 40.6.
Needs a very person-centered approach. Go slow, use a calm voice, identify triggers, maybe they're cold, scared, in pain. Adapt, use warm towels, offer choices, provide reassurance.
Perineal care is part of the bath too, right? Skill 40.1 again?
Usually, yes. Needs to be done more often if there's incontinence, a Foley catheter, or after childbirth surgery. CHG is generally safe for the perineum and external mucosa. Always be professional, preserve dignity. Encourage self-care if they're able.
And back rubs, still a thing.
Definitely. After a bath, it's great for relaxation. Slow, long strokes effleurage can actually reduce anxiety, heart rate, respiratory rate. Just check for contraindications like rib fractures or recent heart surgery.
Okay, foot and nail care, skill 40.2. We touched on this, but the big takeaway for diabetes or PVD.
Do not soak the feet. I can't stress that enough. High risk of skin breakdown, infection. Refer them to a podiatrist for nail trimming or callus care.
But for other patients, soaking is okay.
Generally, yes. It helps soften nails and cuticles. Then clean under nails, dry thoroughly, and file nails straight across. No sharp edges.
And teaching is huge here. Box 40.7, what should patients know? Especially diabetics.
Daily inspection is number 1. Use lukewarm water, never hot. Dry completely, especially between toes. Wear shoes that fit well, always wear socks, never go barefoot. Lotion is okay, but not between the toes, too much moisture there. Trim nails straight across. Promote circulation, wiggle toes, elevate feet, don't cross legs, don't smoke. And report any changes, tingling, numbness, color changes, sores.
Got it. Moving to oral hygiene skill, 40.3, boxes 40.8, 40.9, 40.1. How often?
Depends on their condition. Basic care, maybe twice a day. But for critically ill patients, especially those intubated, it might be every 1-2 hours to prevent VAP.
And using CHG rinses here too.
Yes. 0.12% CHG oral rinses are often used, especially in high-risk patients or those on ventilators, to reduce VAP risk. Use a soft toothbrush. Fluoride toothpaste is standard. No lemon glycerin swabs, they can be drying.
What about unconscious patients? That seems tricky.
It is. High aspiration risk. Their gag reflex might be weak. Best practice. 2 people if possible, 1 cleans, 1 suctions. Or use a special suction toothbrush swab. Position them side-lying, head of bed slightly elevated. Use a bite block or padded tongue blade. And never put your fingers in their mouth. Explain what you're doing even if they seem unresponsive.
Denture care, box 40.0.
Clean them daily. Remove at night, store in water so they don't warp. Handle carefully, they break easily. Clean the patient's gums too. This prevents irritation and denture-induced stomatitis.
Okay. Hair care boxes 40.11, 40.12. Brushing is important for bedbound patients.
Yes, prevents tangles. If hair is tangled, work in sections, maybe use a detangler. Never cut hair without explicit consent.
And if you find lice,
Pediculosis, capitis, head lice. Need a special fine-tooth comb, knit comb, medicated shampoo, follow instructions carefully. Wash linens in hot water, vacuum furniture, prevent transmission.
how do you shampoo hair for someone in bed? Skill 40.1 and 2, Step 16B.
You can use inflatable shampoo troughs that contain the water, or there are waterless shampoo caps now, too. For shaving, an electric razor is safest if they're on blood thinners or have low platelets.
What if they have curly hair or razor bumps?
Avoid a super close shave. Clippers might be better. Don't pull the skin taut. And always ask before trimming a mustache or beard.
Eyes, ears, nose care, table 40.3 again. Any key points?
Protect the skin under nasal cannulas or feeding tubes from pressure. Clean eyes gently, inner to outer corner, water only. No soap, no CHG near eyes.
And for unconscious patients?
Big risk for corneal drying exposure keratopathy. Use lubricating eye drops as ordered, maybe protective eye patches. Clean eyeglasses. For ears, just clean the outer part. Never stick anything in the ear canal.
What about hearing aids? Figure 40.6, box 40.14.
Know the type in the ear, behind the ear. Teach proper insertion, volume control, battery changes, cleaning. Keep hairspray away from them.
Nasal care.
Clean secretions gently. Change tape-holding nasal tubes daily to prevent skin breakdown.
Okay, shifting slightly the patient's room environment. How important is that?
Hugely important for comfort and well-being. Temperature around 68-73 degrees Fahrenheit is usually good. Good ventilation, control odors, manage noise, adjust lighting appropriately.
And the bed itself. Table 40.6.
Hospital beds adjust head up, feet up. Fowlers, semi-Fowlers positions help with breathing or eating. Trendelenburg might be used for shock. Always lock the bed wheels. Side rails are complex, use them appropriately for safety, but raising all four can be a restraint and needs an order.
Bed making boxes 40.15, 40.16, figure 40.0. It seems basic, but any key principles?
Keep linen clean, dry, wrinkle-free to protect skin. Follow medical asepsis, hold soiled linen away from your uniform. Bag it properly, don't shake it. Raise the bed to work to save your back.
What about making an occupied bed with the patient in it, like for Mrs. White?
You work side to side, roll the patient gently toward one side, tuck soiled linen under them, place clean linen, roll them back over the hump, remove soiled, pull clean through. Keep them covered and safe with side rails up on the opposite side.
Got it. So after all that implementation, we hit evaluation.
Right. Did the plan work? How does the patient feel? Use through the patient's eyes. Again, ask about their comfort. Were they too tired? Did we meet their expectations?
And you look at the outcomes you said earlier.
Exactly. Observe their skin. Is it cleaner? Is the redness gone? Ask about their comfort level using a pain scale if needed.
And that teach-back method you mentioned, skill 40.1, step 28.
Crucial for evaluation. Don't just ask, do you understand? Ask them to explain it back. Tell me 3 ways you'll protect your feet. Or show me how you'll use the wash mitt. It confirms actual understanding.
What if the outcomes aren't met?
You revise the plan. Ask why. Do we need different interventions? A specialist consult. Is something preventing the patient from doing self-care that we missed?
How did it go for Mrs. White? Figure 40.11.
She was happier, felt less tired using the adaptive devices, less afraid of falling. But Jamie noticed that skin irritation under her breasts was still there. Mrs. White admitted she'd been embarrassed to mention it persisting.
So the evaluation caught something important.
Yes. It prompted Jamie to consult a wound specialist, and it reinforced that improving Mrs. White's mobility was key to preventing future skin breakdown in those areas.
So it's a continuous cycle of assessing, planning, acting, and evaluating.
Precisely. And always guided by safety, cleanest to least clean, changing gloves, checking water temp, keeping things in reach, knowing about bleeding risks before shaving or oral care. Those safety guidelines are non-negotiable.
Wow. Okay, we really covered a lot there. We went from the basics of what hygiene is, through all the factors influencing it, and deep into the nursing process, assessment, diagnosis, planning, implementation with all those specific skills, and evaluation.
And we saw how clinical judgment ties it all together, using Mrs. White's case to see it in action. It's about being observant, thoughtful, and patient-centered.
It really drives home that hygiene isn't just a task, it's fundamental nursing care. It's about comfort, safety, dignity. It's a real chance to connect.
Absolutely. Every time you provide hygiene care, it's an opportunity for holistic assessment and building that therapeutic relationship.
So we really encourage you, our listeners, to think about these concepts. How will you apply them? How will you ensure your patients feel respected and cared for during these intimate moments?
Keep asking those questions. Keep learning. Keep digging deeper into why we do what we do.
Thank you so much for joining us on this deep dive into nursing hygiene. We hope you feel more informed, maybe more confident as you head into your practice or continue your studies.
Yeah, thanks for listening. Keep up the great work. Until next time.
Keep learning and keep making that difference.